Well, thank you very much, and thanks so much for the organizers inviting me to speak. So head and neck pain, it's a common problem. Let me figure out how to work this advancer here, there we go. So in my experience with the patients I see at our center, 80% at least or more experience headaches of some sort. Jaw pain is equally prevalent, so I'm glad that you've had and will have talks on facial pain and jaw pain. And most of the patients with headaches have common causes, and unfortunately they're often been overlooked. I mean, certainly there's a lot that goes on with you guys, and you know, between your providers and yourself, you're sort of focusing on big ticket items, but day in and day out, it strikes me how often headaches are sort of, put in the back burner. And so there's a lot that I could talk about. There's certainly less common and more EDS specific causes of head pain, and I will touch on those, but I wanted to talk about the more common issues because we've, in recent years especially, acquired or developed lots of more treatments than we've ever had for treating migraines and chronic headaches that are effective, safe, well tolerated. And so let's get into this. So headaches are frequently broken down into so-called primary headaches, meaning that there's some sort of inherent disorder that causes it that we understand some things about, but not as much as we like. So migraine is pretty much the most common and the major primary headache. In the past, there had been, when I was training over 2 decades ago, we spoke of migraines and chronic tension headaches, and the distinctions between these have become less and less clear. And as I mentioned, we have a lot of medications, and they can work on tension headaches versus migraines. The most important thing is determining, that there's not some secondary cause to the headache. There's a structural abnormality, there's a brain tumor, there's sleep apnea, or something else that's causing the headaches. And quite often, patients, particularly zebras, can have more than one cause going on, which makes things complicated. The neck can cause head pain, neck issues can cause neck pain, there can be degenerative disc diseases, there can be musculoskeletal instabilities, and we'll talk about that a little bit. But in terms of migraine, what is migraine? It's an episodic headache disorder, so people have similar headaches recurring with similar features. There's definitely a genetic component to migraine, and for some reason, again, it's an extremely common part of EDS and HSD. And then the environment plays a role. So people can be predisposed to getting headaches, but then, based on sleep deprivation, certain foods, other environmental triggers. Usually migraines last hours. They can last all day, and sometimes they can last several days, and unfortunately, sometimes they can last weeks at a time. Again, some patients will note specific triggers, but more often than not, headaches will happen and there's not necessarily a clear trigger that can be appreciated. Some will be triggered, some won't be, sometimes no triggers identified. Foods can be triggers, red wine, other particular foods. Conversely, missing meals. If somebody goes too long without eating or they get dehydrated, those can trigger migraines. Lack of sleep certainly can be a trigger, but it's too much sleep. So some people, try to catch up on sleep on their weekend, and then they get migraines on the weekend when they're not working. So that's sort of a bummer. Menstrual cycles can be a big cause. Mast cell activation syndrome can be a trigger for migraines and other headaches. Classically or typically, the pain has a throbbing or pulsing character. Migraine comes from Greek, meaning basically hemicrania, or half of the head. So traditionally, migraines have been considered as unilateral, but quite frankly, migraines can be sort of anywhere. The pain can be diffuse, it can be anywhere, and it's more specific features. It's recurring, it has light sensitivity, sound sensitivity, sometimes smell sensitivity, nausea. Again, these sorts of symptoms are very common among all of you, but they're particularly linked or worsened, or they'll happen with the headaches that will help us identify them as being migraines. Some, but not all, people with migraines will have a so-called aura. Most commonly, that's visual. So they'll see zigzaggy lines or flashing lights that tend to occur for 5-20 minutes, and then will segue into them having the headache. Sometimes the aura will persist through the headache. The aura can be other neurologic symptoms. It can be sensory, where one side of the body gets tingling. Migraines can be associated with neurologic symptoms, which can be tricky diagnostically or scary, or lands people in the ER and getting worked up for other causes. So there can be confusion, there can be trouble speaking, there can be dizziness, especially vertigo, spinning can be common. Migraines often have a prodrome, so hours or even days before the actual headache, people may feel tired or find themselves feeling off or yawning or craving sweets. And there can be a postdrome, so even after the headache per se is gone, again, for hours or days, people can feel off. Other primary headache disorders, there's something called cluster headaches. So migraines themselves can often occur in clusters, meaning that you're fine and then you get a bunch of headaches over a short period of time. That's different from the entity of cluster headache, which is very distinct. It happens, comes on abruptly, lasts 2 to 3 hours. It's this intense pain. People with migraines tend to, or typically want to lay down in the dark. People with cluster headaches really can't lay down. They're just too uncomfortable, and they tend to be moving. They're usually behind one eye or the other, and there's tearing. Then there's these trigeminal autonomic cephalgias, or attack headaches, which cluster headache is a type. They can be less severe, they can be more subtle. They do tend to be unilateral, have features like drooping eyelid or red eye or stuffy nostril or tearing of the eye all occurring on one side. They can be episodic or continuous. They're important. They're not super common, but they're important to note because they can respond very well to a particular medicine called indomethacin. Then there's, again, secondary headaches, and in my experience and that of other neurologists, very often what's being thought of as a headache secondary to something else are really a primary headache, or really migraines. So most of the time, or most headaches are migraines, and things like eye strain and other issues get blamed. Those are ascribed to the headache. Certainly other things can cause headaches. Jaw issues, TMJ, can cause headaches. Neck issues, sleep apnea is a common underappreciated cause for headaches. And again, it's not necessarily binary. All these other issues can aggravate migraines, or they certainly can cause headaches. Not everything is migraine. And things that patients are very often very worried about, like, do I have a brain tumor? Do I have an aneurysm? Those things certainly can cause headaches. Fortunately, they are extremely uncommon. Usually they're relatively easy to exclude. And most headaches are a tricky thing, because somebody could be disabled by headaches that happen so often, that are so severe and have so many symptoms, and then paradoxically, there's nothing, MRI's normal, neurologic exams are normal, and that's just the nature of it. So like anything else in medicine, figuring out what's going on is going to help come up with the best management plan. Certainly if there are clear triggers, avoiding those will be helpful. And then treating migraines or chronic headaches breaks down into two main strategic categories: the so-called acute treatment, or abortive treatment, where you've got a migraine, you got a bad headache, here's a treatment or medicine that will hopefully shut that down in relatively short order, potentially within an hour or less. If you just have occasional headaches, acute or abortive therapy is all you're going to need. If the headaches are happening, several times a month, if there's not an effective abortive treatment, then we look at preventive or prophylactic therapy, where you take some sort of treatment to try to prevent the headaches from occurring in the first place. And acute treatments can range from over-the-counter NSAIDs, Tylenol, ibuprofen. Caffeine can be very effective at treating a headache acutely. It can be a double-edged sword. So used occasionally, caffeine can be helpful in treating migraines. Used too often, it can cause a rebounding and kind of promote chronic headaches. For many decades, sort of the main prescription medicine for migraines have been so-called triptans. And I apologize, there's an error in this slide. So triptans bind to, they don't block, but they stimulate a specific subtype of serotonin receptor. And they can have a number of side effects that aren't so good, like nausea or jaw pain, or they can have cardiovascular effects. So then a newer class of medicine, the ditans, are even more selective in the serotonin receptors they bind to. Ergots are an older group of medications. They're not absorbed well orally, so in the past we used them in suppository form, which you can imagine wasn't very popular. They could be given as injections, so they can be used in medical settings, given IV or even intramuscularly. And nowadays, there's actually very effective intranasal delivery systems. Gepants were one of the newest classes, so medicines called Ubrelvy or Nurtec, and they block something called the calcitonin gene receptor peptide, or GCRP, which has been a big breakthrough in how we manage migraines. The triptans come in pill form, they come in nasal form, they even come in subcutaneous sort of auto-injection shots because nausea can be a very prominent problem with migraines, and so it can be helpful to have routes that don't require the GI tract. And so I mentioned the many ways ergots work. Right now, Gepants are just oral. There's a nasal spray that's being studied and probably will be FDA approved soon. Preventive treatments up until recent years have been medicines that have a lot of side effects and baggage to them, using these so-called tricyclic antidepressants, using anti-seizure medicines like Topamax or topiramate. And they can be quite effective, but can have cognitive side effects and weight gain and sedation. We can use beta blockers or calcium channel blockers, blood pressure medicines, which sometimes can be helpful because we also use those medicines for POTS, which may also occur in somebody who has migraines. And then, interestingly, not just for preventive therapy, not just for acute headache therapy, we also have GCRP blockers. Several of them are subcutaneous, so once a month shots. There's an intravenous form, Vyepti, and then more recently we have oral options. So Nurtec can be used as an acute treatment, or it can be taken every other day as a preventative. And then there's a newer medicine, Qulipta, which is a pill. Newer medicines are more expensive than older generic medicines, so the insurance companies can put up hurdles, but usually the companies that make these meds will have copay cards, and depending on your insurance, it may take a little step or two, but usually people can get them. Botox, botulism toxin injections in the face, in the over the head, over the jaw, over the neck, over the shoulders, can be very helpful in preventing migraines. Nerve blocks are often used, so lidocaine, local anesthetics injected in nerves at the back of the head, the occipital nerve, nerves in the face. And by putting that local anesthetic in, it seems to send signals back to the brain and sort of quiet headaches down, and those can provide benefit for weeks at a time. So again, managing triggers is important, managing diseases that may be affecting issues. There are many non-medical treatment options. We talked about diet. Biofeedback has a lot of data behind it. There are a number of supplements that can help, including sort of herbs. Butterbur and feverfew have good data behind them and can be effective. There's a number of recent electrical stimulation devices, something called Cephaly that will stimulate nerves in the face. There's a cutaneous vagal nerve stimulator called GammaCore that can help turn down headaches, be an abortive therapy. Something called Inura, where there's a magnetic pulse delivered at the back of the head from this big boxy thing. These treatments can help. Unfortunately, insurance often doesn't cover them, and they're quite pricey. So despite the best intentions of having acute treatments and prophylactic treatments on board, some patients will break through and have a very severe headache, and we try to avoid them having to go to the ER or urgent care or clinic. But sometimes when there's a very bad headache, we do so-called rescue therapy, which can involve intravenous or intramuscular therapies of different kinds. Many of these can be done at home, and so there's sort of an emergency toolkit for rescue therapy that can be an important part of management. So So I didn't mean for things to go black and ominous, but now I'm going to shift gears and talk about some things that are more particular or can be more particular to EDS and HSD. So Chiari malformation, while something that we'll often see in our patients, is, again, in the big picture, rare, and only a few % of patients have this. It's a structural abnormality, so if you see this MRI scan of the brain, that line kind of shows the base of the skull, and I don't know how well this shows up, but that little red triangle, there's sort of a base of the cerebellum, or it's called a tonsil for some reason, and that normally doesn't protrude below that line at the base of the skull, but sometimes it can sag down and push against the base of the brain and push into the so-called brainstem, which does a lot of important functions, and so people can have somewhat unique symptoms. If they cough or increase their intra-abdominal pressure for a Valsalva maneuver, like you were straining to have a bowel movement, can cause dizziness, can cause swallowing problems, numbness, double vision. Usually a routine MRI is quite sufficient to identify a Chiari malformation. So patients are often coming to me and saying, well, I haven't been worked up for Chiari. It's like, well, yeah, your MRI was normal, and so you don't have that. There are upright MRIs which put gravity into the picture. In some small percentage of cases, you may better see the Chiari, and you don't appreciate it on a regular lying flat supine MRI. Chiaris, sometimes nothing needs to be done about them. Sometimes they're causing a lot of problems, in surgery where the back of the skull is decompressed to relieve the pressure can be helpful. CSF leak is something that people with EDS and HSD can be predisposed to because of connective tissue issues, and there can be slow leak, and that causes the brain to sag down. And you can see on this one, it actually looks similar to a Chiari patient. So we know that the back of the cerebellum, or those tonsils, can hang down. There can be certain findings on routine MRI that we may see, but sometimes we don't. Other ways to look for it, we can try to do routine tests, see if we can see CSF fluid, spinal fluid leaking on an MRI scan of the spine. Sometimes we have to be more invasive and do a so-called myelogram where dye is injected. Sometimes they'll just try a so-called blood patch, injecting your blood and seeing if that closes off a leak and if it provides benefit for a reasonable amount of time. There are some centers that are super expert. There are some centers that do this well, and then there are centers who really don't have great expertise at this. Conversely, you can have too much spinal fluid pressure, and that can cause headaches worse lying down. It can affect vision. There can be sounds in the ears. It can be ringing, or sometimes it can sound like your pulse is in your ears. This can usually everything is normal. Sometimes it occurs because of blockages in the brain, in the veins in the brain, and these can be seen usually non-invasively with MR venograms or CAT scan CT venograms. So that was a quick overview, and in summary, there are, as I've shown, multiple potential causes for head and neck pain. Knowing what is or what isn't going on, doing a careful workup is important. Having an appropriate and multi-pronged treatment strategy involving medical and non-medical strategies, and in some cases, some invasive treatments. Thank you.